everyone. We're filtering in from lunch, but as soon as you're able, please take your seats. I have the privilege of bringing someone exceptional onto the stage. Some of the most powerful shifts in our profession happen when someone helps us see something we've always looked at differently. Dr. Yiannios is one of those people. He challenges us to stop thinking of occlusion as purely mechanical and start recognizing the profound influence of the nervous system on everything we diagnose and treat. When you begin to understand the role of the sympathetic nervous system, how to stress physiology shows up in the muscle activity, parafunction, pain patterns, it changes how you look at your patients. Today, in Sympathetic Nervous System Influence in Dental Medicine, Dr. Yiannios will help us connect neurology, physiology, and dentistry in a way that deepens our clinical lens. Please join me in welcoming Dr. Yiannios.
All right. Am I good? Audio? So I'm a wet-fingered dentist. I'm not used to bright lights and podiums, so you may hear an and or an ah every now and then, right? So, and how do you follow Mark Piper? So he and I have lectured kind of together in the past, and he peels our eyebrows back, and I kind of bring them back down, right? So that's what I hope is going to happen here today. So let's proceed. This little QR code you're going to see for the next couple slides and also at the end, I highly recommend that you click on that to get a PDF of this presentation. There will be things you want in your practice if you're like me. And I'm a wet finger GP. I don't care if you're a specialist or who you are. This is going to be pretty important. There is some novel stuff in here. This lecture is not something, there'll be a few points you've never even heard of before. So I'm a GP, and I love to stick people in the neck. I literally do it every day. I'll do it for all kinds of reasons, and within the hour, you guys will understand why. And Mark alluded to all this. He alluded to the great auricular nerve and the sympathetics and the third order neurons, and we're going to go through that. And I'm kind of like, I've seen a lot with this over the years, and I'm kind of like a dog with a bone. Okay, so a few of you probably know me and know what I've done in the past, and as I get older, I pull away from the internet and all that, but I've seen some things, man. This is a quick intro video.
No.
Okay, so you got a raging toothache, right?
Raging.
Yeah, you walked in here, I don't know, 10 minutes ago. How stressed were you?
I was at a good 9-10.
And we gave you the neck block. What did you do?
It very much relaxed me.
Give me a 0 to 10 on that now.
0, 1.
Seriously?
Seriously.
Yeah. Do you recommend it?
I highly recommend it.
Because we've done it before for you.
I told you I brought my anti-anxiety meds just in case, and I didn't need it.
That's a good thing.
It is a good thing.
All right, thank you very much.
Thank you.
So let me ask a question. What do many cases of hypersensitive teeth, muscular TMD, occlusal dystonia, headaches, insufficient anesthesia, dry socket pain, and anxiety often have in common? I want that to burn in your minds, please. Look where we are. Mark alluded to it, great auricular nerve, that area, superficial cervical plexus. I'm basically, the highlighted area is Erb's point, and we'll get into Erb's point here in a little bit. But Erb's point is kind of the emergence point for superficial cervical plexus, and it's right below the skin, 3 to 4 millimeters deep. And if you drop anesthetic there, it can do a myriad of things. All right, so that's really important. This is part of the QR code, this handout. There'll be a bunch of things on the handout. So what is FDH? Who here has heard of frictional dental hypersensitivity? Anybody? Basically, some Yahoo named Yiannios about, 16, 18 years ago, was playing around with a T-scan, and I was able to reproducibly and objectively figure out how to make teeth less sensitive. Water and air hitting teeth. Who's heard of Robert Kirstein, the prosthodontist, the T-scan researcher? If Robert was Batman, I was Robin, back in the day, okay, many, many years ago. I was fascinated with what he was doing, and he was a researcher, and I was a real-world guy. And I was on the board of advisors of the Academy of CAD-CAM Dentistry back in the day. I was an early adopter of CEREC. if anyone remembers Rich Masick, ACCD. And we invited Kirstein to speak at one of the conferences. And that's where I finally got to meet him. And from there, here we are 16 years later. We're going to talk about FDH, which basically links the occlusion, the dynamic occlusion, to dental cold hypersensitivity. We're also going to talk about something called SDH, sympathetic dental hypersensitivity. Who's heard of that? That was just published about a year ago by yours truly. And the second paper, Mark Piper was co-author. There's a bunch of us involved in that. So what are we doing? It's a newly discovered etiology for dental cold hypersensitivity emanating from the autonomics, from the sympathetics in particular. And then this you'll never have heard of because it hasn't been published yet. ERBSAT. ERBS point, sympathetic anxiolytic therapy. A newly discovered anxiolytic intervention using local anesthetic via third-order sympathetic blocks. That intro video that you all saw, she's an attorney. I live in Walmart corporate country in northwest Arkansas. It's a very affluent place, believe it or not, even though it's Arkansas. And she had a raging toothache. You saw what happened. What I did to her was I injected a little bit of anesthetic in the side of her neck, and she melted. I do this on the regular. I'll do it for the scared prophy patient. I will do it for the patient coming in needing the root canal. I will do it for the patient coming in. We do a lot of root planing with SPRF and lasers, if you guys know what that is. Imagine root planing, adding hard tissue and soft tissue to clean off the root and the soft tissue, drawing blood, spinning it down, and creating S or CPRF, concentrated or solid PRF, dropping that in the pocket, and you get about 2+ millimeters of attachment, reattachment. As an example, I'm kind of a nut. I do all kinds of crazy things, okay? So I want to give you guys context really quick. The 5-second ice water swish. We all have access to ice. We all have access to anesthetic. I promise you, by the end of this hour, you will be able to go home Monday and do something you've never done before.
So tell me, where are you from?
Ireland, Chicago, Pittsburgh,
Colorado, Florida, Missouri,
Canada, Germany, Colorado,
Los Angeles, Calgary, Alberta, Upstate New York,
the Bay Area,
Texas, Memphis, Minnesota, Florida,
Tennessee,
Saudi Arabia,
North Carolina,
Illinois,
Nevada,
New Jersey,
Turkey,
from Spain,
Missouri,
from New Orleans, Canada,
Indonesia,
Australia.
I wanted a dentist who looked beyond just the teeth.
What is it?
I think a 7.
Okay. It doesn't linger, does it?
Just a little slightly on the back.
Back right or left?
Right.
Love that ice water swish. Okay, so it's been, 24 hours?
Yes.
Almost. How do you feel?
I feel better. My bite is definitely different, but it's a good different. When I close my lips together, my teeth aren't clenching down on each other, so it's a little more relaxed.
Yeah?
No headaches this morning.
Do you typically have headaches in the morning?
All the time.
All the time. So this is exceptional. None?
Nothing at all. Wow. Nothing.
So what do you think?
It worked. That's awesome.
How cool is that?
Yeah, that's cool. Wow.
So you glad you had it done?
Yes.
So that video was filmed probably 2013, 14, somewhere in there. Okay, so what in the heck would an occlusal bite adjustment using computerized metrics have to do with decreased sensitivity and less of a headache problem, right? There are times where it's everything, fair. There's times where it's not, though. So as you guys just saw, I used to see people from all over the planet, still kind of do. The older I get, less I want to do that, because it's kind of an ASS meeting, treating a stranger. And something to know, so I developed this protocol that I call neuro-occlusion screening. And it's a hybridization of myself, Dr. Piper, and Dr. Kirstein. So basically, I'm looking for ways to objectively put numbers to TMD, bite, whatever, okay? And this is not just necessarily placed on orofacial pain patients. There are times where I'm getting ready to do a full mouth reconstruction or 10 veneers across the anterior, and something doesn't look right, smell right. There's things I look for. So we'll run it through the screening protocol. So when those people travel from Timbuktu or Mayo or the dental school in California or wherever, basically we tell them first thing when they walk in, we do not want to know why you're here. Sounds kind of opposite, right? I flipped the history taking on its rear. I learned that about 15 years ago. Because a lot of the people in the audience here are aware of that. When you treat orofacial pain, they hurt, they talk, and they talk your ear off, and they waste your time, right? Now, I'm not trying to be unfeeling, but my point is, it's all subjective. So I don't like subjective, I like objective. So basically, by the time you're running through CT, MRI, all these other, this is a biopack, basically. And there's ways that I use the biopack through bioresearch to track like the health of the joints, the muscles, the kinesiology of the mandible, how they're chewing. I get a baseline before and after. So if I do initiate occlusal therapy, I can see if there's an improvement. I mean, who puts a number to chewing? I mean, why do we have our teeth? I'm putting numbers to chewing. I'm using EMG to do that. I mean, I don't want to get too deep, and it's not the point of the lecture, but my point is, you start putting numbers to these things, you have a baseline by which to compare, and all of a sudden you have a permanent record. And I'm not just talking about T-scan data. I'm talking about electromyography, joint vibration, the MRI, the CT, etc. At the tail end of it, then I ask them, so tell me why you're here. 3 or so hours into the morning, they've been through all of the screening, all of the data collection, and I'm talking to them as I show them on the screen what normal is, what they are. What normal is, what they are. So all of a sudden, then when I finally ask them 3 hours in, so tell me why you're here, it's about 3 sentences long. And all of a sudden they understand. And then we hit them up with what? Neck blocks. So neural occlusion screening ends with neck blocks. Why is that? Because as Mark alluded to earlier, I'm testing for other inputs. The biggest thing I ever learned from Mark Piper was there's 3 words: trigeminal, cervical, and sympathetic. And those of you that have trained underneath Mark or heard him lecture have probably heard those 3 words. I cannot emphasize to you how important they are relative to what I've experienced in my global residency, let's call it that, seeing people from all over the planet. These are people, I want everyone in this room to imagine the patient that, oh my God, she's on the schedule again, or send him off to the surgeon. We can't help him anymore. Okay, that's that person, but they live in Australia. All right, so the average number over the years when I'm doing the screening protocols, I'm about the 20th doctor they've seen. The record was number 68th. I was the 68th doc. So you can imagine the kind of stuff that I've seen, okay? And that's enough about me. I want to, there's something interesting though. So throughout all these years, I'm doing neck blocks and I'm using all these digital metrics. And it's all about cold initially. And the allodynia is the pain that's disproportionate to the inciting event, right? It's not supposed to hurt, but it hurts. So when you swish ice water, you have no recession, no exposed dent, no cracked teeth, no caries, no leaking fillings, no leaking crowns, no perio, but they're still cold sensitive. It doesn't make sense. 16-year-old, 18-year-old, beautiful girl, 0 recession, post-ortho, teeth are sensitive. What the hell's going on here? I can't smack it with Gluma or Sensodyne. By the way, I don't use those things. But my point is, the question always came to my mind. When I do a neck block, the vast majority of the time, understand this is something else to know. In my practice, every patient that walks in the door, be it a new patient, because 95% of what I do is high-tech GP stuff. 5% of what I do is orofacial, okay? But over the years, I always have them swish with ice water. The new patient, the orofacial pain patient, whoever it is, I'm having them swish 5 seconds, either swallow, expectorate, whatever, and I'm trying to get a 0 to 10. And then sometimes we'll get like by sextant, like where are you sensitive? But here's my point. The neck blocks are usually temporary, always temporary. If I do a computer-guided occlusal adjustment, it's often permanent, the cold sensitivity. Permanent, not temporary. So that always perplexed me, right? So, this is me 15 years ago. This is me talking back in the day. So again, I practiced in Rogers, Walmart, JB Hunt, Tyson, big deals in our area. Notice solo, corporate, and insurance independent. I will not be told what to do. I love working on my own. I love being able to break new ground, do new things. All right, so I started a teaching center called the Center for Neural Occlusion out of passion. It's not about money. We're lucky if we break even at the end of the year. We see probably a dozen docs throughout a year, and that's it. This is my way of giving back. Some people go to Africa on missions or wherever. I do this. So we're teaching outlier dental medicine. We're teaching people how to think outside the box. Like Jay Levy, I was an engineering major in college. I didn't quite go through it all. I was aerospace first 2 years, but I took all that math. It made me think a little bit different. The engineering calculus will it'll kick your butt. So anyhow, CNO is just something to know about. You all are welcome to come. Our motto, by the way, is measured matters. Measured matters. Putting a number to things. So what's the most important thing? Why are we all here today? Well, what really matters is the patient. What also really matters is family, right? We want to be able to feel good about what we do, help people, go home, and have a life. So my relevant mentors, I kind of mentioned them already. Kirstine and I, this is probably 2013-ish, maybe 12. There's Ed Zibovitz. Ed, I love you, man. He's in the audience, I think. There's so much light on me, I can't see who's out there. And of course, Dr. Piper, love you, man. These guys, they changed my world. They changed thousands of people's worlds, because back in the day when I was dropping those YouTube videos, I think we've had almost 6 million views over the years, and I'm not trying to become an influencer or doing any of that. This is back before that word existed, influencer. I was just trying to push it out to people like us. Initially, it was a T-scan thing, and then it turned into a DTR thing, and then it turned into, all of a sudden it was like, whoa, I'm starting to go towards imaging. Why am I going towards MRI and CT? Because I realized that DTR is not a panacea, right? So I realized that 2/3 of the human body is coming from the joints themselves, the orthopedics. It's not rocket science, but you know what? We really don't think that way. Mark alluded to that super well about an hour and a half ago, right? Displace a disc, have a shorter ramus, things tilt. You guys saw the anomalous videos. So back in the day, I'm an early adopter of CEREC Tech. That was one of the first patients that flew in. That guy was out of South Africa. Kirstine asked me to write a chapter in his first edition of the textbook on the T-scan Bible, I call it, relative to FDH. This is about 2014, 13. So I go down to St. Pete because I'd heard that Piper had his own teaching center. I had no idea. I just happened to hear through the ether. And he and I were walking to lunch the first day, and he kind of walks up to me and he goes, I heard your trouble. I said, yeah? Why'd you hear that? He goes, I like trouble. I was like, okay, yeah, me too. I'm an outlier, I guess. So basically he's like, so what are your theories on this cold thing with the occlusion? And I said, well, I told him my theories. And he's like, did you ever think the sympathetics? And I said, yeah, but there's nothing in the literature. I've spent over a year in the literature. There's nothing there. He goes, it's the sympathetics. That was the first day he and I met. Okay, so that was right before the first edition went out on the FDH theory in that textbook. So over the years, Mark was gracious enough to have me down to the Piper Clinic. I spent a lot of time with him. I also referred a buttload of patients to him and to Ed Zibovitz, and nowadays to Brian Shaw as well. I learned. I had my own patients. I'm in the operating room with my own patients sitting there. Their joints opened up. I mean, what a privilege, right? I was able to understand and see and touch, okay? So geeky me goes in, and over the years, there have been 3 editions of the textbook, and I always participate. I guess they call you a KOL, but the more I learn, the less I know. I can tell you that. And by the way, Mark mentioned this in his lecture. I highly, highly recommend what he posted on that textbook. Let me go back to that. The 25 version, the newest version, that is worth your money. Buy Mark's chapter. He doesn't make money. I don't make money off of this. Maybe $38, I think they charge. Get it online if you want to really learn about imaging. If you want to know the skinny, Mark put that in there for us. Okay? That's important. So I went on to a bunch of other publications, kind of cold-related, TMD-related, but then most recently, like a dog with a bone, I'm on the SDH kick. I'm starting to, we're starting to publish, like over the years, if you go back retrospectively and look at my patient pool of things I've seen, we're having them swish before, we're having them swish after a neck block, and we're tracking results, and lo and behold, it's significant, it's huge, and it exists, and we'll get into that in a minute. The original paper on FDH lies here. The chapter in the textbook preceded that. I need to get moving. So sympathetic neuroanatomy basics, I am not qualified, okay? But I'm gonna give you, I shouldn't say that. I am qualified, I understand it, but it's complicated. I think we all know that, remember? Back in anatomy and physiology, this is complicated stuff in neurology. Basically, the hypothalamus is the integrator, right? For autonomic functions, both parasympathetic and sympathetic. And depending on which section of the hypothalamus you've got, parasympathetic fibers versus the sympathetic, right? So basically the regulatory, heart rate and blood pressure, that's relevant. I will tell you that in the recent papers that we're publishing, we are measuring blood pressure, heart rate, and pulse ox pre-block and then post-block, okay? And that's an objective way of seeing if you decrease sympathetic tone. If I come at you with a knife, what's gonna happen? Right, your heart rate's gonna go up because your vessels constrict, and all kinds of reasons, right? In most places with sympathetics, things constrict. Well, what if I told you after neck blocks, it routinely goes down, systolic and diastolic both, and pulse, statistically speaking, and I can show you the numbers in a little bit. Okay, up and down regulates the immune system. I want to emphasize smooth muscle, regulates internal organs, smooth muscle and glands. And there's our sympathetic chain. As we'll remember, the spinal cord, and on either side we have the chain. Mark talked about this earlier. Controls blood flow. I want you to remember that one thing. It controls blood flow, okay? Blood is life. Remember vasoconstrict. In general, sympathetics vasoconstrict. That's important to remember, those two things. And Mark mentioned this, T1 through L2. We're basically talking about first and second and third order neurons. The first and second are both myelinated. The third are unmyelinated, and that's relevant. And this is our friend, the superior cervical ganglion. And he is uber relevant for dental world. Uber. Not just medical world. And we're gonna go through that today. So when you saw this, I want you to think herbs. GAN is a little bit more anterior. I typically go for herbs, and we'll explain later the different nerves. What I'm doing is I'm targeting these third order neurons of the superficial cervical plexus, the unmyelinated ones. All right, so remember superior cervical ganglion and remember third order neuron. All right, so this is important stuff. There we go again, our highlighted area, herbs point. And over here, we can see the various nerves that emerge from herbs. They include, I can't see this well from this angle, sorry, the great auricular over here. And we've got transverse cervical and supraclavicular and lesser occipital. So these all kind of emerge close to the skin, right about there, okay? And lesser occipital, greater auricular that Mark was going on about, greater auricular, auricle is the ear, right? Notice that fiber goes that way and this one goes towards the mandible. Do we deal with the mandible? Of course we do, right? Right, so now these are cutaneous sensory nerves, sensory. They do not have sympathetic fibers within them, but I want you to remember this always. Those third order sympathetic fibers, they hitchhike like vines around these sensory nerves. There's other ways that sympathetics can make their way to head and neck, but I want you to remember sympathetics. Okay, and they generally emerge from the ventral side of the C-spine, trigeminal cervical sympathetic, trigeminal cervical sympathetic, C-spine. Okay, ventral side, this is where they originate. They make their way up, the third order neurons do, they pop out right here, and that's where we nail them. Okay, I hope I'm clear enough on that. Herb's point, we got that, great auricular, and SCG, there it is again, and I've already made this point. Sympathetic nerves hitchhike along cervical sensory nerves, including, I can't read it from here, reaching targets via gray ray myocommunicantes, okay, the unmyelinated stuff. Everybody got that? There's our GAN, there's our TCN, there's our supraclavicular, there's our lesser occipital. These are third order neurons. There are 4 popping out of Herb's point. We're not going to get deep into this, but basically coming out of the spinal cord, you've got myelinated second order. They make their way into the sympathetic chain, they synapse, and then you've got the unmyelinated third guy, hitchhiking. And I had Grok generate me a kind of a schematic on how we inject. It's not the greatest. I'm going to probably get a medical illustrator on our next paper to do something better. But just remember, there are vines wrapping around these cervical sensory nerves. Okay, so if a physician tells you, oh, there's no sympathetic input from the cervical plexus, dude, they wrap around them. They travel with them. And there's other ways too, and we'll talk about that in a minute. All right, so how do the sympathetics reach the dentition? I don't know if I learned this in dental school. I'm old though. I graduated in '93, and I went to San Antonio. So I learned about A delta and C fibers. Did you guys learn about A beta in dental school? A beta ring a bell? A fly lands on your back you swat at it, that's proprioceptive, A beta, very fast myelinated fibers. So the med guys in med school, they all learned about it. We didn't learn about it. Well, come to find out, they discovered histologically, probably 20-ish years ago, that there are A beta fibers in the pulp itself. What in the hell are touch fibers doing in the dental pulp? It's a hard vault. There's no room for expansion. They call it a compartment syndrome. Why? Right? So back in the day, when I was looking for a reason about FDH and occlusal adjustments, I thought it had to be triggering the A beta, which I had never even knew existed in the dental pulp. But here's the point. 90% of nervous tissue is sensory, cranial nerve 5, trigeminal. But guess what else? They never taught us. Or I don't know, I wasn't taught this. 10% are sympathetic, and they're efferent. In other words, brain sending signals out to something like a gland or a muscle, right? Afferent means to brain, sensory. Remember this? And notice C, A, and A beta. But here's my point. Oh, who here in this audience has ever had trouble getting a lower block on a patient? Everyone in this audience will raise their hand. I wonder if it might be that 10% that we're not hitting. We'll get into that too. So these are the 3 ways that Mark taught me that things make their way into the pulp. Like, how in the heck do they make it from superior cervical ganglion into the dental pulp? Superior cervical ganglion, third order postganglionic, also known as, along cervical sensory nerves such as great auricular. That was one of the 4, remember? Also, following blood vessels of the carotid system, smaller and smaller, down to the pulpal arterioles. And then the trigeminal sheath itself. Okay, and I'm gonna have a bunch of literature references throughout the lecture. Again, please download the PDF. You're welcome to it. And I think we've got one of our papers in there, the more recent one. And here's another thing to know of great importance. There is no parasympathetic histologically in the pulp. So what does sympathetics do? In general, vasoconstrict. What do parasympathetics do? In general, vasodilate. Who here has ever seen, a crown prep routine, a filling routine turn into an endo problem? You're nowhere near the nerve, there's no cracks to speak of, it's a routine thing. 2 weeks later, they're calling with pulpitis. Who's seen that? Come on, everybody, right? Just like we have trouble getting a lower block. Well, there might be a reason for that. So anytime you're cutting on a tooth, you're ramping up sympathetic tone. You're causing vasoconstriction. But who would have thunk it? We don't have parasympathetic to counter it. So that thing squeezes down, and if he squeezes down long enough, guess what happens? You choke off blood flow. What happens if you can't breathe? You die, right? Oxygen getting to cells. Just every now and then I'm going to throw in a very practical tidbit. So basically the compartment syndrome. The tooth is one. And I'm not going to get into this deep because we need to speed up. I want to get you guys to videos. The bottom line is there's no room for expansion in the tooth. So if you have buildup of pressure, right, you can cause a problem. And we're going to go through that here in a moment as well. So there's going to be some things I'm going to skip over. You'll be able to pull out in the PDF. The bottom line, you start constricting when you have the sympathetics activated in the pulp. Okay, and who here remembers tunica media in histology? Do you guys remember that little smooth muscle thing that kind of outline or lies within arterioles and arteries and all that? Smooth muscle, right? So the sympathetics are efferent. Visceral stuff included controlling blood flow and smooth muscle and glands, right? So those sympathetic nerve fibers, how they initiate their, whatever they're doing, their vasoconstriction, they're activating tunica media, that smooth muscle cell, causing things to constrict. Okay, so this is kind of an overview of what they do in general. The sympathetics trigger an inflammatory response. This causes leakage of the blood vessels within the pulp. In other words, it's almost like a garden hose squeezes down, and the outer wall is too thin, it starts blowing out sideways, and you get this buildup of edema. You get swelling. So even though you think to yourself, well, it's vasoconstricting, why would it build up pressure and cut off blood flow? Well, because of the blowout. So this creates that edema that I was talking about, the blowout. And if you have blowout, you can't get the blood going where it needs to go, and lo and behold, things can turn necrotic, for example, with the endo. And it'll cause other things too, in the joint itself, the muscles of mastication, the teeth. So basically, the edema causes hypoxia, which can lead to ischemia, necrosis, and/or claudication, or dystonia. SIDO, sympathetically induced dystonia of occlusion. So, FDH and all this, and SDH, we're talking sympathetic flow. Remember efferents, remember that A beta, the third order stuff. And remember, it vasoconstricts in general, okay? And what do we hit exactly? Alpha 1s. I'm not going to get too deep into this. You guys remember this from school. They cause the contraction. All right? And remember, vasoconstrict when those A betas are activated. Now, let's talk about muscles and mastications in the joints. Who would have thunk it? Superior cervical ganglion innervates the blood vessels within the joints and the TMJs as well, and the muscle. Who here knew that? I know there's a few. In general, most of us didn't know that. So blood flow to the muscles and to the joints themselves are controlled via the autonomic sympathetics. Trigeminal, cervical, sympathetic. I'm not going to get too deep. There's going to be a bunch of these things you guys can read on the PDF. That's why I keep pushing it. The point is, superior cervical ganglion, blood flow, not just to the pulp, muscles and mastication, joints as well. This is important, right? Remember, vasoconstriction. So let's get back to cold real fast. The allodynia, the pain is disproportionate. Swish the ice water. That's an example of an allodynia if it's a confounding case. Touch me barely and it feels like needles. That's not normal, right? That's a problem. So Mark mentioned endotypes, nosology. Endotypes, basically causation. What causes a problem? What truly causes a problem, right? So I'm kind of a hypersensitivity, supposed to be a guru because I wrote chapters and textbooks about the subject. Well, I wouldn't call myself a guru. The more I learn, the less I know. But I can tell you this, presently, to my knowledge, there are 3 endotypes. There are 3 reasons teeth might be hypersensitive. The first would be dentinal tubule flow. We all are aware of that. DH and CDH, right? Ransom and Anstrom and all that stuff. And I believe it was Pashley in the 90s for CDH. And by the way, the DH, usually a occlusal surface and usually a dull pain. And usually they associate that with unmyelinated C fibers. The CDH, a distinction some of you may not know, is that we're dealing with cervical aspect. And typically when you have a CDH reaction or problem, hydrodynamic problem, it's a sharper, faster pain, right? A delta, myelinated faster. C fiber, DH, occlusal, unmyelinated slower. All right, so our second endotype, occlusal excursive interferences. That was published back around 2014 by some guy named Nick. And then our third reason, excessive sympathetic tone. That got published by Nick et al. A year or 2 ago. And no one's heard of it yet, and they probably won't, unless you guys spread the word. I mean, who's looking this stuff up? It seems really boring, but it's huge. Okay, so basically, nowadays, I'm starting to wonder if these 2 guys are kind of related in dental world in general. Now, right now, we're just talking about reasons teeth might be hypersensitive, 3 reasons. So let's talk specifically, and understand another thing I need to point out, dentinal, dental. Do you guys see the distinction? These have nothing to do with dentin. Nothing to do with dentin. Who here has had a patient with sensitive teeth? Again, everyone. Who here has had problems getting a lower block? Everyone, right? Okay, so all of a sudden we're talking about occlusion causing cold hypersensitivity and allodynia, and we're talking about vasoconstricting third order neurons causing a problem as well from lack of blood flow, hypoxia. All right, so let's talk about FDH real quick. This is the thing that I kind of discovered around 2011, 10, somewhere in there. So linking the occlusion to dental cold hypersensitivity, you cannot do it with articulating paper reliably. You can only, I can't do it. I can use the T-scan to do it, and I use it all day long, every day. Every patient that walks in, for even a minor filling, if it has anything to do with the occlusal or lingual surface or buccal, I'm getting a T-scan pre-op and I'm getting a T-scan post-op. Crown, implants, all of it. I'm not pushing T-scan. T-scan years ago tried to recruit me to be their new face, and I was like, no thank you. I want nothing to do with corporate world. But I can tell you that thing is, I cannot practice without it. I own 5 handles I paid full price for. Nothing was given to me. I pay full price for my sensors. It's part of how we practice. And it's way more predictable. All right, so the occlusal endotype, the original paper in Cranio came out in 17, a few years after I published the chapter in the textbook, and we were going on about A beta fibers and torsional flexure and all that stuff. And now, if you ask me many, many years later, I'm going to say that probably wasn't correct. But back in the day, our N was 100, and what was our pre-op? Our pre-op swish was 5.35, our post-op was 1.73. Our p-value, anything less than 0.05 is irrelevant. Look how small that is. Gee, I wonder if it works. It usually does work, okay? So there were my original theories. Mark's like, did you ever think sympathetics? Mark, yeah, I did. And I kind of got excited. I found this about a year ago. It's not really about FDH, but this one slide is kind of important for everyone in this room because it demonstrates if you give a dang about occlusion, I want you to imagine excursive interferences. I'm not talking MIP, CR, FSCP, adaptive, non-adaptive centric. I'm talking about the way teeth come together. And I want you to think to yourself, I'm not just talking the normal bite, I'm talking excursive interferences and movements. When I move off to the right, to the left, I can see with T-scan in 3,000 of a second increments what's hitting when, right? So remember we talked about how the sympathetics, the sympathetic fibers, the third order neurons, hit the tunica media and cause the constriction, right? So this, bang, 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 a lot of speed bumps moving sideways in excursive movement. And this one, less speed bumps. In other words, you're less prone to vasoconstrict. Here, you're more prone to vasoconstrict. And what did we learn about vasoconstriction? It leads to hypoxia. Lack of oxygen might be a problem. Maybe that's why teeth are hypersensitive. They're not of the dentinal endotype. Look at the math. Vasoconstriction by 15% reduces blood flow by 1/2. Vasodilatation by 19% will double said blood flow. I wonder if blood matters, right? We not only need oxygen and nutrients, we have to wash away byproducts of metabolism, muscle, pulp, whatever, inflammatory mediators, etc. This is important stuff for everyday world. So, I love this little military thing because it kind of gives you an idea what I mean by excursive speed bumps, right? I want to get rid of some of those dang speed bumps. And basically, I'm using the T-scan data, and if I'm really serious about it, I'll have them melded to EMG, but everyday world, general practice world, I can do some amazing things just with T-scan alone. And I'm basically looking for these excursive rubs on working and balancing. And Kirstein's theory has to do with timing. My theory is a little bit different. There's a little center of force icon, that little kite in the middle that's the average sum force of all these different things touching. I like to straighten that guy out. In other words, as he's moving off to an excursive movement, you've got this little doohickey moving off to the right or to the left. Well, it should be a smooth course, geometrically speaking. Kirstein measures time. I think there's too much subjectivity in time, because when you ask a patient to move sideways and don't think about how fast you're moving, it doesn't work for me. What works for me is tracking that geometrical diamond and straightening that line out. Those little bumps along the way, when I get rid of them, the speed bumps, and straighten it out, I'm not having as many tap, tap, taps, which aren't ramping up sympathetic tone. So there's sympathetically induced dystonia of occlusion. So you get enough sympathetic, excessive sympathetic flow, that can lead to all kinds of problems. In the occlusion, in the muscles, in the joint. I'm not sure, I can't remember if Mark talked about this, but the joint itself, the condylar head, that too is a compartment syndrome. Just like the tooth, right? No room for volumetric expansion. Hypoxia, excursions. This is all important stuff.
So tell us what just happened.
Yeah, well, I had sensitivity to cold water, and then you, doctor, adjusted my whatever, I don't know.
Your bite with a computer.
My bite with a computer.
Yep.
And it's completely gone. I don't have sensitivity
Yeah,
anymore.
give us a swish.
Yeah.
So they put a crown in years ago.
Mm-hmm.
They never got the bite right.
Mm-hmm.
Yeah. So we adjusted your bite using the computer data.
Yeah.
To guide our way.
Completely different. Night and day.
When you swished an hour ago before you came in here, what was that?
I could feel it. Well, it was a 5. It wasn't like excruciating.
And now?
But now it's nothing.
Is that pretty cool?
Yeah, it's really cool.
That was in hygiene. That was not a orofacial pain patient. As I said, I use this stuff every day. The original version of T-scan, that's been retired about 6 or 7 years ago. And there's the new version, the Novus. And who here knows how accurate articulating ribbon is in the literature? Any idea? Relative to force and time, 12 to 38%. Analog and subjective. It's an opinion. All right? The marks that they taught us about in school, it doesn't cut it. I've been doing this way too long to know. In the literature, how accurate is the T-scan? 95 relative to force and time. It ain't perfect, but it's way better than the ribbon. And why do I say 1/3? Because 2/3 of the occlusion in my head are the joints bilaterally. Joint, joint, teeth. Mark taught me that years ago too. All right, so this is digital objective, and I have a record of the occlusion. What hit when? That's relevant many times. So then we've got the cervical endotype now. So when I mean cervical, I'm talking neck, not cervical aspect of tooth. Trigeminal, cervical, sympathetic. So sympathetic dental hypersensitivity, a newly discovered etiology emanating from the autonomics relative to anxiety. Remember I said in the beginning of the lecture, I stick people with, in the neck with needles every day. You'll start understanding why by the end of the lecture, and we're getting close. Why in the heck would this guy's teeth be sensitive? Someone give me an answer. This guy flew in from Hollywood. I can't say names, of course. He's got 2 vital teeth, apparently. It was time for him to spruce himself up. He's one of the fly-ins, right? Okay. Why in the hell would he swish a 4 out of 10 with the ice water? And why after T-scan EMG, and I ran him through screening, MRI, CT, et cetera, all the other stuff, why after that occlusal adjustment would it be a 1 out of 10? Anyone have an explanation for that? This is the kind of stuff I see over the years. Mark sees it, Brian sees it, Ed sees it. Why? Well, we're calling it sympathetic dental hypersensitivity, excessive sympathetic tone. Vasoconstriction, hypoxia. Okay? So this is the original paper. At the very end, we mentioned SDH. And basically, I try to remember the number here. What was our N? 91. The pre-op swish was 6.4. The post-op was 3.9. The p-value was pretty dang small, really relevant. So we asked Mark to come on for the second one. We did a much larger study, retrospective. 194 was the N, pre-swish 6.4, post 2.4, another small p-value. The bottom line with SDH, and this is the new stuff, right? ERB-SAT as well. 1/3 had no change after the injection to the cold, remained, to say it was 4 out of 10 pre-op, it's 4 out of 10 after we injected. Okay, didn't change. 1/3 of them, we had partial change. So maybe they went from a 4 to a 3, but they still had some sensitivity. And again, what they state or write down is analog, it's subjective. So you gotta take that with a grain of salt. But 1/3 of them went from a 4 to a 0, if 4 was the number. Complete change. A neck block, coming at Erb's point. Great auricular is what we were targeting there. Nowadays, I'm going more back towards Erb's point because I want to hit all 4 that emerge from there. So why is that? What in the heck could putting a little bit of anesthetic in the neck do to make the teeth less sensitive? What's that have to do with teeth, right? Trigeminal, cervical, sympathetic. So this is me in a real-world practice explaining to you all, you people who are like me, how Dr. Piper's stuff applies to everyday practice. Forget the fly-ins, forget the fancy stuff, forget all that. This is everyday stuff, and you're getting ready to get blown away by more. So what do I use to inject, right? Well, there's something called the phrenic nerve, kind of below SCM. I don't want to get anywhere near that guy. That's motor innervation to the diaphragm. I don't want to hit drop anesthetic and have trouble breathing on that side. All right, so what I do is I use an ultra short 30 gauge. It's 12.7 millimeters long, and I never sink it more than 1/3 of the way. You can go a half, but don't go deeper than that. You do that, you're gonna be fine. The spinal accessory nerve is somewhere along there too. Worst thing that happens, SCM, maybe trapezius, I think it's trapezius, might go a little bit numb temporarily, who cares? But I am worried about phrenic nerve. So you worry like, well, what I need to worry about? I'd worry about the phrenic nerve and that's it. Mark, have you ever hit the phrenic nerve? I never have either. Ed, you? Or Brian, anybody? I don't know who's out there. So you have to almost want to hit the phrenic to hit the phrenic. You don't do this and you'll never screw up. Because I believe it's deeper than 13 millimeters. Okay, so there's our JN and there's Erb's point. Nowadays, I'm shooting Erb's point. In the past, I was going here primarily. Okay? No phrenic nerve, as we mentioned. Now we're starting to get into some more detail. Cold
5 seconds.
allodynias.
What do you got? 10's the worst pain ever.
About 7, 8.
All right. Little poke. Was something changing already?
I don't know, I still feel some burning over here, but not much over here.
Think about that.
Burning behind the eyes.
So the burning behind the eyes over here just went away,
It seems like it.
Burning pain behind the
but you
eyes.
still have it over here. The sympathetic thing, remember the hitchhiking nerves? That can cause the burning sensation.
Okay.
Swish the ice water again. Because we just did it a minute ago. Tell me if it's different.
The bottom I didn't feel much earlier, now I don't feel any.
Yep.
Up here, I felt some, but now I only feel it from here over.
This is one of the screening patients. This is not an everyday patient. I think this one was from Canada, if I remember right. So what happened here? Well, the sympathetics cause an inflammatory response. They're blowing out that garden hose, the blood vessel, right? They're causing edema. And the edema cuts off the blood flow, leading to hypoxia. All right? I'm not sure, in her case, it doesn't get to necrosis. There's enough blood flow to keep things alive, but decrease the hypoxia, and they lose their cold sensitivity. I'm not sure why, but I've seen that for a lot of years. All right, so now we're done talking about cold, and we're gonna start talking about muscle for a minute.
A few months ago, I came in and was having severe left-sided jaw pain. I couldn't even, like when I would open my jaw, it felt like someone was stabbing me.
What do you do for a living?
I'm a nurse practitioner.
Yeah, so what did you think? What did you think was wrong?
I thought it was my TMJ, but I have like popping on this side, and I was like, I don't understand why this would be popping. I put a little anesthetic in my neck, and it numbed it up, and the pain like went away immediately, and then it was gone for like 24 hours, and then exactly the 24-hour mark, I started to get feeling back in my jaw.
And then it was kind of normal?
Yeah, I mean, it was probably like 5% of what it was. I could actually open my jaw without having tears in my eyes.
Yeah.
And then, gradually over the next few days, it went away completely.
So ever since, no issues?
No, I haven't had any issues.
That's awesome.
Yeah.
Sympathetics, autonomics.
Yeah, it's amazing.
It's not just trigeminal. Yeah.
Right,
It's cool stuff.
amazing.
Thank you very much.
Thank you.
So hypoxia, claudication, and or dystonia. Dystonia, muscle stuff, right? Similar mechanism. Where's it coming from? Superior cervical ganglion. What is it? Third order neuron.
Okay, so tell me what brings you here.
3 weeks after wisdom teeth.
Whenever I open my jaw past here, it tends to hurt on the left side, and then whenever I press on it, it kind of hurts.
Okay, so you had your wisdom teeth out about 3 weeks ago, and things were fine.
Yeah.
And then all of a sudden, a couple days ago, it started swelling again, right?
Yeah, it was just swelling like this.
Let me see how wide you can open. That's it, huh?
Mm-hmm.
Okay. You all right? Does one feel different?
This one feels different.
This one feels number, doesn't it? So you know what this laser energy is doing right now?
No.
It's making more blood flow. Is it better than it was, or?
Yes, a lot better.
80%, 50%? What do you think?
It's 80%.
Try opening. Is it hurting?
No.
When you walked in, was it hurting?
Yes.
So can you open bigger or not?
Bigger, I feel like.
And less pain?
Yes, less pain for sure.
Awesome.
Similar stuff. So I was a little bit pissed off by my surgeon. The guy I referred to, the oral surgeon locally, he wouldn't see her because it was 3 weeks post-op and she didn't have an infection going on. That actually kind of worries me because it's supposed to be 5-6 days, something like that, right? And why do I say it worries me? Because of the CRIP stuff, because of the ramped up sympathetic stuff, the dysautonomias that Mark's talking about. We all have it in our practices, whether you identify it or not. My last patient before I left here Tuesday, I almost didn't make this meeting. I walk into my hygiene, I've got an MD psychiatrist there, and she can barely talk, and she's trembling. She's 45, she's healthy, and she's starting to describe all these weird sensations. She's got dysautonomia going on. Guess what I do? And for the first time in about a year and a half, she had relief. And I explained to her as I was doing it, I was in a hurry to get out the door, But this is, I'm not gonna say everywhere, but it's in more places than you'll believe. And I'm not looking for this stuff. I just know how to identify a lot of this stuff. The more I learn, the less I know. Now that lower block, guess what? We figured out why you won't go numb. Then sympathetic. Feeling that? Open for me. Close. You good? You tight? Your coat. Not too bad, is it? Stay back and relax. Perfect. Now stop again if it's trouble. If you're still feeling, I'm going to do it one last time and then we're down. Okay?
Yep.
Is that better? In the same spot I wasn't in again. You guys get it. We're going to move on. So this morning we did 2 fillings in your upper right.
Yes.
It gave you a neck block. What the hell was it like? What did it do?
We were talking about it, and it reminded me of I haven't had a mimosa in a while, but it reminded me of a mimosa. But as soon as I leaned back and just started to kind of get ready for the procedure, I was really relaxed. And I don't think I've ever been that relaxed ever in my entire life. Maybe when I was a baby and I had no idea what was going on. Yeah, right. But that's it.
So 0 out of 10, how sensitive or anxious were you initially?
I was like a 7 or an 8.
And after with the neck block?
It was like a 3. And that's if that just me assuming. I just was more relaxed, more ready for the procedure. Even during the procedure, I was like, my body automatically gets tense, but I was like, hey, I can relax. This is okay. Yeah. So I noticed myself relaxing, and I don't think I've ever done that before, ever.
Recommend it?
Absolutely. And I was very hesitant, but I was like, you know what? If it makes me less anxious, I'm all about it.
Yeah. Cool. Thank you very much.
Thank you.
Anxiety. What's that all about, right? I never see anxious patients, do you? Yeah. So an NYU study came out last fall, I believe it was, and 72.6%, I think it was 1,000 adults, were found to be anxious. So yeah, we all see it. The majority of our patients are anxious. And now with a couple of drops of anesthetic, you know how to make them not anxious, if it's sympathetically induced. All right, so in my experience, probably 90-95% of the time, if I drop about 0.3 to 0.4 cc's, I'll typically use Marcaine. On Herb's point, boom. Sympathetic, parasympathetic. We're writing the paper right now. Mark has the draft in hand. And when I first sent these things off to Dr. Piper, he sent me back an email. I didn't want to throw that up, but I asked Grok, does anxiety upregulate the pain response? Heck yes, it does. And Grok, I've been training Grok about the herbs injection. And initially when I first started talking to him, her, it, whatever it is, it was like, no, that's not possible. And then I explained further, I'm saying, hey, we've got vines hitchhiking on cutaneous nerves. It's not cervical plexus itself. It blew Grok away. There is like, that is novel. So, HerbSat, sympathetic anxiolytic therapy, newly discovered. So Mark and I are on the phone last summer, 2 hours or so, putting the SDH paper to sleep. And I told him before we hung up, I'm like, I'm gonna start doing this on normal patients. That's how this came about. The next day I started injecting and we started noticing, holy cow. Holy cow. I don't have time. You've already seen this. Download the PDF. I want to hit you guys with some more videos. This is the data that we have in hand right now, not yet published, will be within a month or two. The N is 89. Look at the p-value. Is that pretty small or what? So 0 to 10, anxiety, 3.7 to 1.5. Notice also that there are systolic drops and there are diastolic drops. Guess what else drops? Their pulse. Guess what remains the same? Pulse ox. Oxygen saturation. Pretty cool. So, what do many cases of hypersensitive teeth, muscular TMD, occlusal dystonia, headaches, insufficient anesthesia, dry socket pain, and anxiety often have in common? The sympathetics, right? There's that QR code again. If you missed it earlier, grab it now. I'm going to show you guys a few more videos because we have about 8 minutes. Oh, CNO2, if you ever want to learn about screening, I've never done the whole thing and we're doing it for 3 days. you all are welcome to come. CNO6, we did that last October, Dr. Zibovitz and I. Sympathetics and TMJ imaging, that can be done online. That exists presently for AGD credit. Please join the Facebook group if you want to kind of keep track of what we're doing, what's going on with the CNO crowd. It's free. Be sure and answer the questions and tell me that you're a medical or dental professional. I'm the only guy that lets people in. Now, extra videos. I never knew if we'd get there.
Like you're getting up out of bed. Yeah, that's all I needed. That flex you just did right there. Okay, hang tight. This is going to poke a little bit.
Executive at Walmart just had an implant placed a week prior.
You okay?
Coming in for dental work on her top.
Yeah, because that bruising and that swelling, this may actually help a little bit. Not instantly, but now give me an R30. You were sore when you walked in, right?
I was. And that's taken the edge off it, so I can still feel the sensation of it, but actually it's not as deep ache as it was before.
And it has been for days?
It has been since I got, well, first couple of days it was okay, then it's kind of as the healing started, you start to feel that.
And they did grafting and all
Not grafting this time was just the implant
they inserted
on the graft. But it was the second one that we had done. So it's not, it's more painful than the last implant I had done, but not as painful as the full stuff that I had when I had all of the dental grafting, bone grafting done. So it would have been great to have something else that might have helped with that.
Yeah. So basically this was how many days ago?
That was last Friday, so 7 days.
So 7 days ago, and okay, this is sore, swollen. We injected the greater auricular nerve and it made a big difference.
It did.
What percentage?
I think it's about 75%.
Perfect. Thank you. Yeah, that's important.
Remember we talked about DH, dental hypersensitivity, dull, C-fiber, unmyelinated. Did you hear her talk about dull pain, unmyelinated, right? Third order neurons. So she started out first day or two, you know, not too big a deal, but now it's a dull ache. It's because it's sympathetic. I want you to think about how that can apply to your practice. Extractions, crowns, root canals, root planing, name your stuff, implant insertions. All right.
Not too bad, huh? A wreck or something, right?
Car wreck a year and a half ago.
Yeah.
A lot of neck pain on this side, no relief. Couldn't turn my head, couldn't turn.
Physicians couldn't figure out. The chiropractor, what did they do?
We did a year and a half chiropractic, we did physical therapy, nothing alleviated the pain or the discomfort.
Describe the pain discomfort.
Most days, probably a 6, 7, sometimes an 8. More of a dull pain, but just a very tight, muscular cramping, very concentrated to this area.
You feel good still?
Yeah.
So it's been a week, right?
Since a week and a day.
Yeah.
And even like my posture's more relaxed. Like I'm not,
wound up.
There's not the clenching and I hadn't noticed that, but I have a women's group I meet with.
I'm going to cut this one short.
And they
basically, headaches. Her next step was ablation. She'd been to all the chiropractors, all the physicians, all the neurologists, et cetera, et cetera. They were going to ablate nerves. She had so much chronic pain. I'm not going to tell you I cured her, but I can tell you I hit her the first time for normal dental work, and she's like, oh my God, what did you do? The next day, phone call. I'm like 50% better. Nothing has helped me at all. I have her back a week later, hit her again. She's like 80%. Hit her again. About a week after that, 90%. I just saw her last week, and she says 90, 95% better. No, you don't need to.
I can hear out of my ear.
You couldn't hear 10 minutes ago?
Not very good, no.
And you can hear better?
Yeah.
Wow. I'll be down. Our ENT friends would like to see this. So let's summarize. What happened? You climbed a mountain in Utah.
Yep. Came home. I got off the mountain. My ears were, I couldn't hear anything out of them really, and then they went back to normal, and then when we left Utah, they pressurized again. This year released later, and this year remained for a while, and then it's pretty normal now. After
so you walked in, it had been several days, it's still been messing with you, right?
Yeah.
And now you're better?
Yeah, pretty much. I feel like
you can hear normal.
Yeah, out of this year I can.
I'll be damned.
Well, okay.
It's the Sympathetics.
What, 7 months ago we first met? What was going on then?
This side of my face hurt,
Yeah.
and when I'd swallow, it felt like I had a sore throat, but it wasn't my throat.
Yeah.
There was nothing wrong with my throat. And it was very painful.
And you had trouble swallowing and
Yes.
drinking
I
and
couldn't swallow, drink, or anything like that.
so we hit you with a neck block. We put anesthetic in the side of your neck.
Yes.
The great auricular nerve, right?
Yes.
We did it multiple times.
Yes.
What happened?
I didn't notice relief right away, but within just a few minutes, I could notice a change.
Yeah.
That it was better.
And now here you are 7 months later. Do you still have the problem, or has it kind of gone away?
None whatsoever.
So when the injection happened, that made a big difference, and it's lasting.
Yes, so far it has.
That's amazing. 7 months out.
Yes.
Thank you very much.
It's the Sympathetics.
Okay, so you flew in from Canada.
From Canada, yeah.
What were your problems?
Pain, neck, jaw, ear, eyes, sensitive teeth,
Yeah.
difficulty masticating.
Yeah, right side primarily.
Right side, yeah.
Seen a bunch of doctors, bunch of dentists, bunch of chiropractors.
Dozens, absolutely.
Yeah, no resolution.
None.
So what do we do today? Reading through screen, right?
Yeah.
MRI, CT, all that stuff. Explain to you trigeminal cervical sympathetic. And then we give you a neck block on your right side.
Yeah.
What happened?
Immediate relief of the pain in my eye, the discomfort in my throat, which
Trouble
was
swallowing.
creating difficulty swallowing. Yeah.
dysphagia.
Pain on the side of the ear has now dissipated as well.
Yeah. So you were like a 7 or 8. Now you're a
Yeah. A 1.
pain level, right? So then we gave you the cold water because we were thinking, well, maybe it's coming from the neck. Well, it was still bothering you.
Yeah.
After we gave you the neck block, we gave you the ice cold water.
Equally as uncomfortable.
So then I hit you with laser ozone
Yeah.
a couple of minutes ago. What happened?
I have full resolution of all symptoms on both sides of
The
my
cold
mouth.
is-
It's completely comfortable. I just
Yeah.
finished that entire glass while swishing and enjoyed every every sip. Yeah.
All right, so we were trying to. That's pretty cool.
Yeah.
All right, I gotta quit. Laser and ozone is the cure for dental hypersensitivity, by the way. Works 98% of the time. I gotta quit. Thank you.